Good evening, everyone. I am Precious Diane Orocio, and today I will be discussing the cephalopelvic disproportion or CPD, the shoulder dystocia, and macrosomia. So it is very important for us to know as future nurses on what are the things, the interventions that we will be doing when we encounter these things on our patients. Sit back, relax, and enjoy the discussion. So what is CPD? CPD or the cephalopelvic disproportion is a pregnancy complication in which there is a size mismatch between the mother's pelvis and the fetus head. This can make vaginal delivery dangerous or impossible. So CPD is a rare childbirth complication and it occurs when your baby's head doesn't fit through the opening of your pelvis. So the baby's head is proportionally too large or the mother's pelvis is too small to easily allow the baby to fit through the pelvic opening. Now, what causes cephalopelvic disproportion? So we have here first the contracted pelvis. This occurs when a woman's pelvis is smaller than normal in any important pelvic measurement or diameter. So the baby might not fit to your pelvis if the opening is too small. So we all know that the ideal pelvis of childbirth is the gynecoid pelvis because it is large enough to fit the baby's head and the baby's body. Next, we have the pelvic exostosis. So these are the bony growth on our pelvis. So pelvic exostosis, it is a benign growth that projects outward from the bone surface of the pelvis. Exostoses are capped by cartilage and arise from a bone that develops from cartilage. So exostoses happen when we get injured. So a damage to a bone can make it regrow incorrectly and in a form of an exostosis. Next, we have the spondylolisthesis. This is a condition in which a bone in the spine slips out of its proper position onto the bone below it. So spondylolisthesis can be caused by the degeneration, trauma, or the congenital defect. Next, we have here the large size baby. So this can be caused by gestational diabetes and other conditional that cause a baby to be a macrosomic. So a baby weighs 4,000 or 4,500 grams or large for its gestational age. So next, we have here the signs and symptoms on why the cephalopelvic happens on the mother. So first, we have the prolonged labor. It is characterized by labor that lasts 18 to 24 hours after the regular contraction begins. So it is very important for us nurses to know on when does the contraction of the mother start and when does it ended. So it is important for us to know also on when does the due date or if the due date of our patient is already prolonged. Next, we have here the fetal distress, signs before and during childbirth indicating that the fetus is not well. So fetal distress is very important to always check because fetal distress could risk the baby. It could either kill the baby inside the womb. Next, we have the high levels of amniotic fluid. So too much amniotic fluid causes the uterus to become larger than average. So if the patient is first time in labor and it lasts 20 hours or longer, that could be a sign of CPD. And if the baby's head isn't moving toward the pelvic opening, and also contractions aren't strong enough to move the baby along the birth canal, or slow or no thinning or dilatation of your cervix, so it could be a sign of CPD. Next, we have to diagnose CPD. So CPD is subjective clinical assessment based on physical examination and course of labor. So antepartum, the clinically ability to predict maternal pelvis fetal size discordance leading to arrest of labor, or suggestive findings or intrapartum. So how is CPD treated? So first, we have the vacuum extraction or forceps to ease your baby through your pelvis. Next, we have the C-section or the cesarean birth. It is a procedure that removes your baby through an incision in your abdomen. So the common thing that the physician do when a mother experiences CPD is through the cesarean birth. Next, you have the complications of CPD. So CPD is very uncommon and complications are even rarer. First, we have the premature rupture of membranes, and we have the dystocia, extreme molding of the head, umbilical cord prolapses, and then the fetal distress, damage to the mom's perineum, injury to the baby's head, and we also have the uterine rupture. And those are the things that could happen when our patient or the mother experience or develop the CPD or the cephalopelvic disproportion. So the next topic that I will be discussing is the shoulder dystocia. So what is shoulder dystocia? So it is when a fetal head is delivered but the shoulders are stuck and cannot be delivered. So shoulder dystocia is a failure of the shoulders to traverse the pelvis spontaneously after the delivery of the head. Shoulder dystocia, it is when the anterior shoulder becomes strapped behind on the symphysis pubis and the posterior shoulder may be in the hollow of the sacrum or high above the sacral promontory. These are the things that causes shoulder dystocia. First, we have the fatal macrosomia, we have obesity, diabetes, mid-pelvic instrumental delivery, post-maturity, multiparietic, anencephaly, and the fetal ascites. So those are just some of the things that causes the shoulder dystocia of the baby. So next we have here the complications of shoulder dystocia. We have the maternal and the neonatal. First, we have the maternal. We have the lacerations of the bladder, urethra, vagina, anal sphincter, or rectum. We also have the lateral femoral cutaneous neuropathy. We have the postpartum hemorrhage, the symphyseal separation, and the uterine rupture. Next, we have the neonatal complications. First, we have the brachial plexus palsy. The brachial plexus nerves run from your baby's spinal cord in their neck through their arm. These nerves are responsible for providing feelings and movements in your baby's shoulder, arm, and hand. Damage to these nerves can cause weaknesses and paralysis on the affected side. Then next, we have the fractures to your baby's collarbone or the clavicle and the upper bone or the humerus. So your baby could also experience a Horner syndrome. So it is a rare neurological syndrome that affects the eye and the surrounding area on one side of the face. So those are just some of the complications that could a baby or the mother experience due to the shoulder dystocia. The signs and diagnosis. The delivery may have been uncomplicated initially, but the head may have advanced slowly and the chin may have difficulty in sweeping over the perineum. Once the head is delivered, it may look as if it is trying to return into the vagina, which is caused by the reverse traction. And also diagnose through maneuver. Next, we have the initial response. So the initial response is a pre-procedure steps and consideration. So the first thing we need to do is to call for help. The physicians will order for some extra nurses that could help during the procedure. And then follow general principles of basic care and prevention. And lastly, perform episiotomy. Have here the initial maneuver, which is the Macrosomia maneuver. It is a procedure to correct shoulder dystocia during childbirth. So the Macrosomia maneuver, it is a legs flex onto the abdomen, causes the rotation of pelvis, alignment of sacrum, and opening of birth canal. Then after that, the suprapubic pressure applied to the fetal anterior shoulder. As what you can see on the photo, so that is the Macrosomia maneuver. As you can see, the nurse put the suprapubic pressure on the fetal anterior shoulder so that the baby could be delivered. Next, you have the secondary maneuver, the Rubin, the second rotational. So it consists of inserting the fingers of one hand vaginally behind the posterior aspect of the anterior shoulder of the fetus and rotating the shoulder toward the fetal chest. What you can see, the fingers are inserted vaginally behind the posterior aspect, and then the baby has been rotated the shoulder toward the fetal chest. So those are the maneuvers that we need to do, especially when the mother or the baby is experiencing shoulder dystocia. Next, we have the post-procedure care. First, we have to repair the episiotomy. If needed, provide emotional support to the woman following a traumatic birth and possible death of the newborn or injury to the baby. So the last topic that I will be discussing is the macrosomia. So what is macrosomia? It refers to a very large body size. It is often used to describe an oversized fetus. And macrosomia is a medical term for when a fetus is overly large prior to birth. Big babies could cause or can cause several complications during pregnancy. Babies that weigh more than 8 pounds or 13 ounces when born are diagnosed with a condition called fetal macrosomia. Next, we have the causes and the symptoms of the macrosomia. First, we have having a family history of fetal macrosomia. We have excessive weight gain during pregnancy, have diabetes or were diagnosed with gestational diabetes, and also we have a pregnancy lasting more than 40 weeks and a fundal height. So it is very important as a pregnant woman to always be careful. So weighing gain or weighing weight during pregnancy is normal, but it shouldn't be excessive. Next, we have the major complication of macrosomia to the baby. First, we have the shoulder dystocia, clavicle or the collarbone fractures. We have a childhood obesity and the high red blood cell count, which increases your baby's risk of jaundice. So these are just some of the complications that the baby could experience when the baby have macrosomia. Next, we have the major complication of macrosomia to the mother. So first, we have injury to your birth canal, genital tract or perineum, heavy bleeding or postpartum hemorrhage, uterine rupture, longer labor especially during the pushing phase, and also changes in your baby's heart rate during labor. So those are the complications that we should be careful, that we should always know and check the baby's weight so that we, at the end of the day, when we experience or when we go through labor or when we give birth, we will not experience macrosomia. Next, we have the prevention. So get regular prenatal care, watch your weight, and if you have diabetes, take appropriate steps to manage it. So actually, fetal macrosomia is unforeseeable and isn't diagnosed until after the baby is born. So since a baby's weight can't be accurately predicted during pregnancy, it is very difficult to predict if your baby will have fetal macrosomia. So it is very important as a mother or as a pregnant woman to always take good care of yourself, and especially that you have a baby in your womb. So those are the things that has been assigned to me. We have the CPD or the cephalopelvic disproportion, we have the shoulder dystocia, and the macrosomia. I hope you learned something on our discussion. Thank you and God bless.